very much, Professor. It's an honor to be here once again in Ho Chi Minh, a very nice city and a beautiful city, of course, with beautiful people as well. For this morning, I'm going to share with you clinical pearls in the diagnosis and management of thyroid nodules. These are my disclosure information. I will not be stating any unapproved use of any drug in this presentation. Over the next couple of minutes, we will try to discuss the different considerations when evaluating thyroid nodules. We will also describe the recommended approach in the workup of thyroid nodules, and we will discuss the recommended follow-up of thyroid nodules. As my title says, we're going to talk about clinical pearls. This is not the pearl I'm going to talk about, but we're going to talk about the clinical pearls. What are clinical pearls? They are best defined as small bits of freestanding, clinically relevant information based on experience or observation. If you remember our old consultants, they would often tell us, during my time, this is what I saw, and this is what I bequeath to you as a knowledge. Often, these bits of information are passed from one generation to another of doctors, and so we call them clinical pearls. The good thing, however, with more recent developments is that information does not come only from observation, but we now have a lot of information from clinical trials as well. So we have a very robust information with us. And this is perhaps the basis of the clinical pearls that we have today. And the pearl that I'm going to discuss with you is the pearl that is found in the thyroid. That is the thyroid nodule. How do you define thyroid nodule? In the past, a thyroid nodule is just a palpable lump in the thyroid gland. But now, the more important definition of thyroid nodule is, it is a distinct lesion that may be differentiated from the surrounding thyroid parenchyma, and this is the more important part, by ultrasound examination or other sensitive imaging. Thus, the use of imaging technology is now very important when defining a thyroid nodule. From a physician's point of view, that is what we need to know. But when we talk to our patients, when we go back to our clinics, there are three very important questions that our patients will ask us, and hopefully we will be able to answer correctly. One question is, Doctor, do I have a thyroid nodule? Second question is it dangerous, the one that I have here in my neck? And lastly, does it have to be removed? I'm sure you have encountered a lot of patients who will tell you, Doctor, treat me anything except surgery. Thus, if it is important for us to give them assurance that this nodule should not be removed, then it is important that we know which ones should be removed and which ones should not be removed. How do we assure our patients? Basically, we do three things. In medicine, we have been taught that the best way to give your diagnosis is elicit a complete history, perform a thorough physical examination, and do the rational diagnostic tests. So we will go about our discussion in this format. Let us begin with history. When we talk to our patients, there are pieces of information that are already clues for us to say whether this nodule is something dangerous or not. And this includes getting the patient's age, personal or family history of thyroid disease, especially cancer, a previous radiation to the head and neck, the rate at which the mass in the neck grows, the presence of pain, dysphonia, dysphagia, and dyspnea, symptoms that are related to over or underproduction of the thyroid gland, and the use of iodine-containing drugs or even supplements. In the Philippines, we do have a lot of patients who use supplements, and I'm sure even here in Vietnam, We have a lot of patients who tell you, Doc, I'm taking this particular supplement. Is it safe? And then you start looking at the label and says it contains iodine. These are the things that we must ask our patients. And the reason why we want to answer these particular questions is because there are people who are prone to develop thyroid nodules. And there are 4 distinct populations who are prone to develop thyroid nodules. Who are they? The elderly, females, people from iodine deficient areas, and those with radiation exposure, particularly to the area of the head and neck. So, when you have a female patient above 70 years old who comes to you in your clinic and has had prior exposure to the head and neck during childhood, then suspect probability of thyroid nodules. But more than the nodule, we are more interested in knowing which of these nodules tend to be malignant. And based on history alone, there are some clues that we can already gather. 1, extremes of age. If a patient comes to you less than 14 years old or more than 70, they might have a greater likelihood of having a malignant nodule. 2, males. Even if males tend to have lower frequency of thyroid nodules, once a man has it, there's a higher likelihood that it is malignant. 3, the rapid growth of the nodule or the characteristic growth of the nodule will give you a clue whether it is malignant or not. Presence of dysphonia, dysphagia, and dyspnea. These are, of course, all pertaining to obstructive symptoms. Then, a history of radiation, particularly in childhood and the area of the head and neck. And finally, the family history of medullary thyroid carcinoma, as mentioned by Professor Mapausi, MEN2, or even papillary thyroid carcinoma. These are 6 of very important clinical information which, when present in your patient, makes the likelihood of a malignant nodule higher. When we talk about the growth of the nodule, however, our professors tell us that there is a very important clinical pearl, and that depends on how rapid a nodule develops. Depending on how rapid a nodule develops, it can be benign, malignant, or a hemorrhage in a cystic nodule. Those that are longest, slow growing, tend to be benign. Those that grow within weeks or months with progressive growth tend to be malignant. But those that grow the most rapid are the ones that have a sudden hemorrhage in a cystic nodule. So these are examples of clinical pearls handed down from one generation to another, and yet are still very much true based on clinical evidence. From history, let us go to physical examination. And I'm sure all of us, during our medical years, have been trained on how to palpate the thyroid. We have 2 approaches, whether you use the anterior approach, or what is shown here is the posterior approach. Personally, and of course when I teach my residents, the posterior approach is more sensitive because our fingertips are able to palpate the thyroid much better when we are behind the patient. But what are the things that you must palpate in order for you to focus on the thyroid nodules? 1, detect the volume of the thyroid and its consistency. Of course, we must make sure that the thyroid is soft, doughy, without any nodule. A presence definitely would be abnormal. If there is a nodule, what is the location of that particular nodule? What is its consistency, size, and if ever you can determine accurately the number of nodules based on palpation, much better. Is there tenderness or pain? And finally, do you palpate any palpable lymph nodes? These are the focused findings that you must look for whenever a patient comes to you with a thyroid nodule. So our professors tell us, practice, practice, practice palpating the neck. But the thing is, Are you actually confident that your hands are sensitive in palpating the neck of the thyroid of your patient? And I would like to share with you one very interesting study that compared the sensitivity of the hand of a physician with a high-resolution thyroid ultrasound in detecting thyroid nodules. And mind you, this particular study was a blinded study who enrolled experienced physicians already from as long as 5 years of practice to 33 years of practice, looking at more than 2,400 patients. And what did it show? If you rely on your hands, based on this particular study, your hands will miss 79% of nodules. Imagine that. 79% of the nodules you will not feel with your hand. But, more interestingly, your hand will overdiagnose nodules as much as 68%. Even if they're not there, you will say, oh, I think you have a nodule. But in reality, there's none. So what does that make your patient? Oh my, I have a nodule. What will happen to me, doctor? You make them nervous by saying that they have a nodule, overdiagnosing with your hand. And the thing is, if you look at the size, a nodule that is less than 0.5 centimeters can only be detected 1 in every 100 of the patient. So that's 6 in every 100 patients. So that's actually a very low sensitivity. So even if our professors tell us to practice palpating the neck, do not trust your hands yet. But there are things that we must always remember. There is still value in what our professors tell us. In that, careful inspection and palpation will always be recommended because there are certain examination features that suggest an increased malignant potential. What are these? If you palpate a firm and hard nodule, higher likelihood that it is malignant. 2, if it is a fixed nodule, it is highly malignant. And 3, if you palpate the presence of lymph adenopathy at the cervical area, then most likely it is malignant. And I'm sure all of us here have at one point been able to palpate such findings. So still we can trust our hands. But then again, this particular study tells us that there might be a need for us to do something more than just palpate the neck. And in fact, this particular meta-analysis is very interesting in that it quantified the cancer risk of the clinical and ultrasound features in 41 studies of more than 29,000 patients. And if you just look at the clinical features, having a family history of thyroid cancer increases the risk of thyroid cancer twofold. And having a history of head and neck irradiation increases the risk of thyroid cancer 1.5-fold. As mentioned here, males tend to have higher risk of having a malignant thyroid nodule if it is present. So, always ask, does your family have a history of thyroid cancer, and have you had irradiation to your head and neck? After history, after physical examination, that's the time you order for the rational tests. And based on current recommendations, there are 3 important tests that we must order. First, check the thyroid function tests, thyroid hormones, and even antibodies if necessary. Request for a thyroid ultrasonography. And finally, if indicated, do a fine needle aspiration biopsy. What are the important things when you request for your TSH and thyroid hormones? First, you want to make sure that this patient comes to you either with euthyroid symptoms, hypothyroid symptoms, or hyperthyroid symptoms. And thus, the TSH should either be low, normal, or even elevated. In patients with low or suppressed TSH, we want to make sure that they are not hyperthyroid. So the next step is to do your free T4 and your T3. If the TSH is normal, then basically you don't have to do anything else. Your patient is euthyroid. But if it is elevated, then you might need to make sure that your patient has a T4 and even a TPO antibody test to find out if they have positive anti-TPO that will lead you to hypothyroidism. Now, why would you want to do a TSH in a patient with thyroid nodule? Because several studies have shown that there seems to be a unique feature of TSH between benign and malignant nodules. This particular study was able to show that if you look at the TSH of patients who underwent thyroidectomy, those with benign thyroid nodules have TSH levels still within normal, but in the lower range of normal. In contrast, people with malignant thyroid lesions, particularly differentiated thyroid carcinomas, tend to have a median TSH that is in the upper reference range, or even in the upper half of normal. And so, the TSH can already give you a clue as to whether the thyroid nodule is probably benign or probably malignant based on just the TSH alone. But of course, let us not be too hasty because this is just in an ordinary blood test and it's not really confirmatory of malignancy. And you will need further tests. And one such further test is none other than the thyroid ultrasound. And in fact, several international organizations, both in America, in Europe, and even in other parts of the world, recommend thyroid ultrasound in all patients with thyroid nodules, particularly those who are at risk for thyroid cancer, those who have palpable nodules, and those who have lymph node enlargement suggestive of malignancy. So, order for a thyroid ultrasound if you are entertaining malignancy, and if in your PE there are signs that the nodule could be malignant. Speaking of thyroid ultrasound, I do not want to preempt the lectures tomorrow, but let me just give you a few concepts about thyroid ultrasonography. We know that the patient is of course placed in a supine position and the probe is placed in this particular part of the neck, and what you will see in the image is this particular organ, the thyroid. And if your patient has a nodule, that nodule may be seen in any part of the thyroid parenchyma. Now, what exactly is this particular structure? And I'm sure tomorrow we will have more detailed discussion on this. What you see there is none other than this structure here. This, of course, is the thyroid. Then you have the trachea. And of course, you have your internal jugular veins and your muscles here. So whenever you use the thyroid ultrasound machine, just remember that this part here is more important. And in fact, this is the transverse view, which is the more important view to look at when interpreting thyroid nodules. Of course, on thyroid ultrasound, you have to describe the nodule. And what are the important things that must be reported? You must report in a single nodule the position where it is located, the size of the nodule, what shape it has, and I'll tell you in a while why the shape is very important, margins, if they are clear or not, what is the content of the thyroid nodule, are they hypoechogenic, isoechogenic, and do they have certain vascular features? If, however, you have multiple nodules, which one do you report? The thing is, when you have multiple nodules, there are things that must be done. And the correct way is to report the nodules with the characteristics associated with malignancy and not just the dominant or largest nodule. For some of us, you might say, It's easy to describe the largest nodule. Why not just describe the largest one? But that large nodule may not be the more suspicious nodule. And so it's important that you describe those that have the suspicious features. And let me share with you the result of a meta-analysis looking at ultrasound features of nodules. And according to this meta-analysis, these are the features associated with increased risk of thyroid cancer, and I hope that the radiologist and sonologist will report their findings in this way. Nodule height greater than width, absent halo sign, microcalcifications, irregular margins, being hypoechogenic, the nodule structure, particularly if it is solid, and the presence of intranodular vascularization. But if you look at the odds of being malignant of these features, it is the very important shape of the nodule that gives you the tenfold risk of being malignant. And what is that shape? Being taller than wide. Thus, in a transverse view, if the nodule is taller than it is wide, then that makes that nodule highly likely to be malignant. And so it's important that you look as well in the picture that is accompanying the ultrasound report, especially if you're familiar with how it is done. But, of course, we rely as well on our sonologists to tell us that the nodule is taller than wide. But if you will notice, as far as the heterogeneity is concerned, there are heterogeneous results in the different findings. But one which gives you the most homogeneous result is none other than the absence of a halo sign. What is a halo? A halo is one wherein there is this very, very thin line that actually covers the entire nodule. So that is a halo, that particular dark line there surrounding the nodule. So if you don't have a halo, such as this particular nodule, that makes that particular nodule highly likely to be malignant. In fact, it is 7 times higher likelihood to be malignant if you don't have a halo. So how do you remember the absence of a halo is bad? I think this is the way to view it. The absence of a halo is bad. And that for me is one way for us to remember looking at the halo. But if you look at the different findings in the thyroid ultrasound, we know that the American Thyroid Association has already come up with its recommendation that you just do not look at a single finding. In fact, they tell us that looking at the risk of malignancy, you have to consider several findings altogether. This can range from one finding to even as high as 6 findings suggestive of being benign or highly malignant. But then after this was published, the American Association of Clinical Endocrinologists, the American College of Endocrinology, and even the European Association came up with a simpler way of trying to look into the risk of malignancy on ultrasound. And they only have 3 categories: low, intermediate, and high. According to them, a nodule on ultrasound is considered to have a low risk of malignancy, approximately 1%. If it is mostly cystic, more than 50% of the nodule is fluid, isoechogenic, and spongiform in appearance, or with regular halo. That makes it likely benign. Then, according to them, an intermediate risk nodule shows hypoechogenicity with ovoid to round shape, but there's ill-defined margins. There's increased vascularization inside the nodule, and it tends to be stiffer on elastography. You can also have continuous rim calcification and even spots of uncertain significance. Quite very hazy. But more important for us to remember is the third part, which nodules are highly suspicious to be malignant. These are the nodules that have marked hypoechogenicity, spiculated or microlobulated, with microcalcifications, as I mentioned to you, taller than wide shape, and the evidence of extrathyroidal growth and adenopathy. Thus, with these three means of classifying, we now have a simple way of looking at the risk of a particular nodule, whether it is benign likely or malignant likely. But the thing is, when we read a report of the ultrasound, sometimes you're not given that. You are not given the likelihood that it is benign or likelihood that it is malignant. Instead, the sonologist gives you all the different findings. This patient's ultrasound showed hypoechogenic with continuous rim, etc. So you're bombarded with all of these findings, and they seem to be the pieces of a puzzle. But for us to make meaningful use of these several findings, it is important that we put all of them in a meaningful way so that you come up with a complete picture. So, looking at thyroid ultrasound is similar to looking at the elephant from different perspectives. You might actually be looking in front and view it differently, or be looking at it from the back and interpret it differently. But the more important part is for you to be holistic when it comes to interpreting thyroid ultrasound. And thus, the aggregate features of the thyroid ultrasound will be your guide to detecting and saying whether there is a need for you to do the third test. And what is that? The fine needle aspiration. And this is a very simple way of looking at which particular findings will make you likely recommend fine needle aspiration biopsy. Because not all our patients would not want their neck to be poked. They will tell, Doc, I don't want any needle going inside my neck. So, if the ultrasound says it's purely cystic and spongiform, perhaps you can tell them, okay, I will not refer you for fine needle aspiration, but if you have elevated stiffness, suspicious ultrasound features, and abnormal lymph nodes, definitely not referring them for fine needle aspiration is unacceptable. And having said that, now, when we look now at fine needle aspiration, it is important to look at the size. And I would like to give you a very simple clinical pearl. What are the sizes of the nodule that will make you ask for fine needle aspiration? Just remember two numbers, 10 and 20. More than 10 millimeters, more than 20 millimeters. Request for fine needle aspiration in patients with high ultrasound risk, even if they're greater than just 10 millimeters. Request for fine needle aspiration if they have intermediate ultrasound features and are more than 20 millimeters or 2 centimeters. And finally, request for fine needle aspiration biopsy even if they have low ultrasound risk features if they are very big, more than 20 millimeters, and increasing in size or associated with a risk, history, and prior thyroid surgery. Just remember 10 and 20. Doctor, if the patient asks us, why do you not want me to undergo biopsy? Why is it that you're not recommending biopsy for me? Then your answer must be clear. There are 3 and only 3 very important indications why you will not recommend a biopsy. If they have a low clinical risk, with nodules with a major diameter that is very, very small, less than 5 millimeters, nodules that are functional, are thyroid scintigraphy or thyroid scan, and hot areas on radioisotope scan. Because we know that studies have shown that a hot nodule is less likely to be malignant. So these things can guide you. And you can tell your patient, you know, you're doing good, you have these features, just go home, and enjoy. I will not do anything else. But when a fine needle aspiration is done, there are important terminologies that must be used. And according to the Bethesda system for reporting, these are now should be the standard ways of reporting fine needle aspiration results. Non-diagnostic or unsatisfactory, benign, atypia of undetermined significance, AUS, or follicular lesion of undetermined significance, FLUS or FLUS, follicular neoplasm or suspicious for follicular neoplasm, suspicious for malignancy, and finally, malignancy. Now you might say, where did they get all these terms? And what are the significance of all of these words? The thing is, all of these have an estimated risk of being malignant. A non-diagnostic or unsatisfactory smear only has a 1 to 4% of being malignant. Benign, only 0 to 3. But if your aspiration says it is malignant, then it is almost always sure that it is really thyroid cancer. But is it really just that easy? Can you really trust what is written in the thyroid biopsy report? The thing is, they did a study looking at the actual risk of malignancy of these different categories. And you will be shocked to know that a non-diagnostic or unsatisfactory smear has as much as 20% of being malignant. So the actual risk is actually higher than what is estimated. So if you get a report from the pathologist that your smear is unsatisfactory and non-diagnostic, be worried because it can be malignant 20% of the time. But if you get a report that says it is suspicious for malignancy or malignant, then you can almost be certain and tell your patient that the patient needs to undergo surgery. And finally, once we have this report, it's time for us to manage the patient. And management can also be viewed in the form of this triangle that I showed you, similar to the results of the ultrasound. You have benign, atypia of unknown significance, or follicular lesion of unknown significance. You have your follicular neoplasm, suspicious for malignancy, and malignant. And depending on the result of your FNA, then your patient can either have very low risk of being malignant to very high risk of being malignant. And your management will change because those patients with very low to even low risk of malignancy may be managed conservatively, but those who have indeterminate to even very high may need to undergo surgery. And so, depending on what you find on the FNA, then your recommendation will be different. Benign lesions may be followed up with a repeat ultrasound and perhaps even a repeat biopsy even after a year. Those with atypia of unknown significance may just need repeat FNA or consider repeat ultrasound based on clinical data. But those with suspicious and even malignant features need to undergo surgery and intraoperative pathology and even total thyroidectomy for subsequent radioactive iodine management if indicated. In the US, because more and more molecular testing is available, they recommend molecular testing if available. Unfortunately, in our part of the world, this is not something that we have. So we can base our decision on the fine needle aspiration that we have. So let me end my talk by giving you 3 pearls. The first pearl: thyroid nodules must be evaluated in people who are at risk using the aggregate historical data and physical exam findings. Do not forget, thorough history and very complete PE still is very important for us clinicians. Workup of thyroid nodules involves serum testing for hormone levels, Imaging is very important, using thyroid ultrasound and FNA to give you the cytologic classification. And finally, the treatment strategies for thyroid nodules should be properly guided by our assessment of the cytological class, and therefore, our management will be tailored depending on these findings. And all of this that we want to learn will hopefully translate to the benefit of our patients. Thank you very much.